This is hip operations case proposal by May D. San Jose for JHU Operations Management. The goal for this case proposal is twofold. One is to improve the number of surgeries completed in a 10.5-hour working day to at least 7 or more, and to improve patient flow surgery times. This is upon the call of the Director of Orthopedic Surgery at the hospital for any suggestions for operational improvements. Bottom line for this case proposal is consider hiring CRNA and a physician assistant, adjust arrival mean time of patients, strongly consider dedicated OR track for higher BMIs, identify other adjustable performance improvement process without creating too much variability with staffing and equipment. Increasing patient flow times, of course, increases the probability of completing more surgeries in a given workday. All things being equal, meaning all the medical professionals are of equal high-level competencies, all equipment are of high-level quality and efficiency, these goals are very interrelated in a sense that one could be proportional to the other. Additionally, there are several studies that show that risk of complications from prolonged surgeries adversely affect patient health outcomes. Chang et al. Conducted a literature analysis of pooled observation studies that showed this correlation between poor health outcomes and increasing operative times. To be known as an efficient surgery center can also likely benefit the bottom line profits. Positive reviews and recommendations due to quality care is a powerful instrument to leverage trust, experience, and marketing, especially in this age of influencers, online reviews, and viral videos. Other arguments for bottom line: economic analysis of cost utilities related to surgery is of a particular importance to the bottom line profit of any hospital. Given that joint surgeries alone costs are expensive on average, the cost further extends to other resource allocation, staff, overall equipment, from sponges, instruments, medications, and technology to post-op rehabilitation. For this case, I'm using the provided pre-built AnyLogic simulation model, which is a powerful modeling tool to support discrete events. Surgeries, as we all know, are discrete events having clear start and end times, occurs at specific scheduled times, and involves discrete resource allocation. I want to mention that having the simulation demo on 10.5 hours per workday will not be enough to observe the surgery processes. So I did at least 5 to 10 replications to provide an adequate review. And in this slide over here, you could see a high patient flow times and also some of the pain points. So in a nutshell, the current Hipkins operating room for knee and hip surgery setup shows high percentage of utilization in the areas of OR, anesthesiology, and at times the surgeons. These are all adding to bottleneck situations and jams in afternoon appointments. These hotspots are also resulting in rescheduling of surgeries, which adds to complicating surgery times and increased patients' anxiety and waste of deployed resources, not to mention adding the cost of repeating the process and the use of these resources for the rescheduled surgeries. First proposal is to add 2 CRNA and 1 physician assistant into the pool and implement a consultative collaborative model. This simulation shows that there have been improvements in the anesthesiologist track, and also you will notice that there have been significant improvements in the average patient flow times on both tracks, and more importantly, we have at least increased the surgeries completed in a given track, on a given workday. Doing the simulation again, one more time, and fast forwarding it, kind of does the same results too. Showing one more, and there you go. The argument for CRNA versus a physician anesthetist is the cost-effectiveness modeling that has been published in 2010 and revisited in 2018. Both simulation studies concluded that while not always feasible, allowing CRNAs to practice independently, that is to be consultative, collaborative model, it shows at least costs per procedure with the greatest net revenue. The cost-benefit analysis is also shown in this slide, followed by the other arguments for additional tasks during downtimes that could benefit both the medical, the patient, and the family. Additionally, CRNAs and physician assistants are variables that are predictable to manage and measure. In addition, for the downtimes, as mentioned, or surgery delays or cancellations that could be utilized, they could be utilized for other tasks like monitoring patients, post-observation in the recovery room, and talking to the families in the waiting room. These are tasks that add value, especially on the utility and psychology lens, and also assures patients and families that they are provided quality and personal care. These adjustments also provided less utilization of surgeons who can take turns talking to families and patients, or provide feedback to the team, or even take a couple of minutes to break to get ready for the next surgery. So for other improvements, on this slide, I wanted to bring you back that although we have improved patient flow times, increased surgeries to 6 per track, and improved the anesthesiology utilization, the persistent pain point in the past simulation with adjusted CRNAs and physician assistant pool, the persistent pain point is still in the OR utilization area. So in this simulation run, we have adjusted the arrival mean to both tracks at 100 from 90, which improved the OR utilization, and by doing more runs, it has persistently performed between, let me see, you have 74% and 81%. Doing it again, I'm doing this right. You have 68% and 78% now utilization of the OR tracks. In this slide, I present the argument for proposing that it is important to consider adjusting a patient-related factor of BMI. Assigning a track for these cases that hits a BMI of 30 and above. BMI is a good predictor of surgery cases, time and completion. So in this slide, it shows the hip-up case table 2 in here. It shows that patients with BMI of 30 and above consist of 55% of the cases. Those with a BMI of 40 and above, the average procedure time is at 115 minutes versus 98 minutes for normal weight, with a standard deviation of 30 minutes versus 10 minutes for normal weight. So the benefits of dedicating an OR for these cases are outlined in this slide. But for this proposal, I also would like to mention potential concerns that could be part of a mitigation brainstorming sessions, if you will. It could be seen as discriminatory, that's a given. May create resource allocation changes. It might affect teaching opportunities. It could also impact OR utilization if there's not enough cases for those with BMI 30 to 39 or above 40, for which I doubt, since BMI trajectory in the general US patient population has been increasing over the decades. So in this slide, just want to show the metrics comparison between the regular OR and the proposal for dedicated OR for the BMI cases of 30 and above. And as you can see, there are regular OR improvements, increasing cases from 5 to 7 per day, reducing turnover time by 37.5%. A dedicated obese OR benefits increase from 3 to 3.5 cases per day, which could provide for better resource utilization. So the overall impact, it combined increases of 2.5 cases per day. That's good. Average utilization improved to 87 to 88%. It could potentially reduce overtime needs and better predictability for all cases. The data shows this approach could significantly improve both efficiency and predictability. In addressing the case on the 4 lessons of variance, pooling, utilization, and psychology, definitely variance hurts in surgeries. Again, referencing the BMI table 2, BMI category showing increasing procedure time, variability, which makes it harder to reliably schedule 7 surgeries, increased risk of day-end cancellations due to underutilization. With a targeted 20% reduction in variance, simulation modeling could evaluate impact on schedule reliability, better reduction potential, probability of completing all scheduled cases, OR utilization improvement. So this data suggests standardizing procedures, especially like for higher BMI patients, could meaningfully improve throughput. Pulling the OR and anesthesiologist, pulling those factors did not do much change in utilization and actually increases average flow times in the model. I don't propose to pull surgeons because you need a dedicated team, especially the surgeon, for their patients to assure and enhance the patient-physician relationship, trust, and confidence. In this slide, utilization matters. The graph shows the optimized process. So based on the analogic model analysis, here are some of the key findings. Current state, 40-minute turnover. There's utilization gaps between cases, 47% OR time, 18% high turnover time percentage. Cases drop significantly. Cases often gets bumped to the next day, and then utilization drops significantly after 3 p.m. On the optimized state, there's a 25-minute turnover, more continuous case flows, high active OR time at 74%, reduced turnover percentages, and maintain higher utilization throughout the end of the day and accommodate 7 cases within the schedule. However, utilization should not be maximized at the expense of patient safety, teaching requirements, that it is a teaching hospital, the quality of care, and staff well-being, like reasonable workloads and breaks. And last, psychology matters. Yes, it does matter in these cases for several key reasons. In the patient side, patients getting bumped to the next day creates significant dissatisfaction. Long wait times increases anxiety for patients and families. Perceived waiting time, of course, can feel longer than actual waiting time, and uncertainty about surgery timing adds stress. For the staff side, a teaching hospital environment creates pressure balancing education and efficiency, and surgeons completing their 4 to 5 cases a day to private practice 8 cases per day may feel very frustrated. End of day case bumping can demoralize staff. So to address these psychological factors, suggestions could be looking at perceived waiting time versus actual time, like implementing real-time tracking system in the waiting rooms, creating family liaisons during turnover periods, or setting up comfortable waiting areas with clear communication channels. On the staff psychology side, interventions could be creating structured teaching moments during natural process pauses, develop clear performance metrics that include teaching quality, implement team-based rewards for meeting turnover targets, establishing clear communication protocols between OR groups, and regular team debriefing sessions. So by focusing on these key performance indicators, improvement proposals, HIPKINs can optimize utilization of their surgery resources for improved patients, staff, and hospital health outcomes.